Good afternoon, and welcome to the Editor's Podcast for the Journal of the Academy of Nutrition and Dietetics. I'm Dr. Linda Snetzler, Editor-in-Chief of the journal. And with me today, I have Linda Gigliotti, who is an RDN and first author of the article entitled Incretin-Based Therapies and Lifestyle Interventions: The Evolving Role of Registered Dietitian Nutritionists in Obesity Care. Welcome, Linda.
Thank you, Linda. I'm happy to be here.
I'm going to begin with a question that's quite general. We do continue to be interested in obesity in our nation, and I was wondering, what are some of the statistics showing in terms of age categories and gender-specific data in this area?
Sure. We know that obesity, the incidence of obesity has certainly increased in the United States, particularly over the last 60 some years. Now, the figures are that obesity impacts about 40% of adults in the United States, with the highest prevalence found in the age group between about 40 and 59. What's interesting when we look at these statistics is that it seems that maybe, at least over the last few years, that the prevalence of obesity has been stable. But if you look at subcategories, there's been a shift with an increase with those with severe obesity. Now, over 9% of adults are categorized as being in that category of severe obesity. Also, while I'm saying obesity here, we have to look at the other category of overweight. And we have over 30% of adults in the United States classified as overweight. So when you put the two together, we have over 70% of adults in the United States impacted with the disease of either overweight or obesity.
Staggering statistics.
It really is. And I think of more importance, maybe, is the impact that it has on our healthcare cost in the United States. It's estimated that overweight and obesity account for about 47% of the annual total chronic disease cost in the United States. So that's a public health crisis.
Most definitely. Your article focuses on incretin-based therapies, and that includes the new generation drugs. How do these drugs work mechanistically, and what results are we seeing in terms of weight loss?
Yeah, the incretins are actually hormones that are naturally secreted in the gastrointestinal tract in response to food. They're specifically categorized by their ability to reduce serum glucose. When we take in food nutrients, it stimulates insulin secretion from the pancreas beta cells. And then, of course, the glucagon secretion from the alpha cells of the pancreas are reduced. But what we see with these hormones is that they have a very short half-life, about 2 minutes, I read. So the medications were developed to really exploit the actions of these naturally occurring incretin hormones, initially for the treatment of type 2 diabetes. I mean, these incretin medications have been around for 20 years and other, forms developed over there, but 20 years ago was the first incretin medication used for the treatment of diabetes. So the medications then actually are agonists, receptor agonists. So we refer to GLP-1, which is the hormone, and then GLP-1RA, receptor agonists, which are analogs of the hormone. And these receptor analogs have been shown to actually activate the GLP-1 receptors in numerous tissues and organs of the body. And I think that has importance when we look at the potential for these medications to say they work several areas. Now, the relevance for weight management is that in the gastrointestinal tract, these receptor agonists can delay the gastric emptying and delay glucose absorption. That promotes greater satiety between meals. They have actions in the pancreas where they promote the release of insulin, which in turn helps to regulate blood glucose and appetite. They also act on some parts of the central nervous system. So there's that decreasing cravings or food noise that people talk about. So overall, the impact is a significant decrease in appetite, in addition to this management of blood glucose levels, which is why they were used first initially for diabetes. But early weight loss medications of different categories. So weight loss in the range of 5, maybe 10%. What's remarkable about these incretin medications is that we see much more significant weight loss. Semaglutide, particularly out of the STEP 1 trial, reported about a 15% mean weight loss. And then tirzepatide, which is the dual agonist of GLP-1 and GIP, in the SURMOUNT-1 trial, reported weight losses of up to about 21%. I mean, that's bordering on the range of weight loss that we can see with bariatric surgery. So that's what has really caught everybody's attention with these rather remarkable medications for obesity care.
Thank you. Excellent explanation. In your article, you indicate that counseling by an RDN paired with an incretin-based therapist may be critical in supporting adherence to the medication. Please add to that statement with some additional detail on how that might be accomplished by the RDN.
I think the first thing to note is that these are serious medications. They're not to be taken casually. I know we've seen a lot in social media with personalities out there who have reported using the medications and their phenomenal weight loss. And that has led, I think, to a lot of hype about almost promoting these as magic pills, if you will, for weight loss, but they're not. Obesity is a chronic disease, and I think that's something that's really important to emphasize. So these medications can be one of the tools to be used in obesity care, but they're serious medications. So from the RDN's point of view, I think there's really two goals, two ways that we can be instrumental to the support and success, really, for our patients. One is to help our clients adhere to the medication protocol. There are side effects related to the use of the medications. And let's face it, if our patient isn't following the medication protocol, is having difficulty tolerating the medication, and they're not taking it, they're not going to be getting the desired effect, whether it's for glucose management and or obesity management. So most of the side effects, when they're experienced, are in the gastrointestinal tract. Well, RDNs are, we know the GI tract. We're quite effective at helping people manage things like nausea, vomiting, constipation, and so forth. So we can really help our patients initially with working through adjusting their intake, the size of the meal, perhaps lowering the fat content of the meal, spacing things out, going with easily digested foods, addressing fluid intake, which is super important, especially for constipation. Most of these side effects are mild. They're transient. They tend to occur, if they occur, they tend to occur at the time of dosing. And then the patient adjusts and can tolerate the medication. But with these medications, there's the protocol is to step up the dose generally every 4 weeks or so. So the client may experience side effects with each injection, which is weekly, or may experience more side effects when the dose is stepped up. So adhering to the medication protocol is really one, I think, really important area for counseling. The other area where the RDN, I think, really is important is to help the client making the lifestyle changes for the long term. And this requires a shift in our thinking. So often as dietitians, we've worked with our clients who want to decrease their weight, adipose tissue. We've worked with them on a calorie deficit plan, a diet, if you will. That's not as necessary for most clients taking these medications because there can be such a suppression in appetite. We often do not need to be talking about a calorie deficit, but in fact, sometimes we need to work with our clients to make sure they're getting in enough calories for adequate nutrition and health. Instead, we now have the opportunity to focus more on the quality of the intake. What do they need for long-term health, for chronic disease management, especially if we're working with a client with other chronic diseases such as diabetes, cardiovascular disease, and so forth. The good news is that when our clients are feeling positive because they're losing weight, and that's been one of their major goals, they're often more receptive to making the changes in their food intake. And since a decrease in food noise is reported by most people taking these medications, they often are more receptive to making the changes because they have a lessened desire or trigger to eat or to use food for other reasons. So I think those are the two categories or two areas for our counseling where we have a very critical role. One, to help with adherence to the medication protocol. Second, to help that client make lifestyle changes for long-term health management.
Thank you so much. Beautiful summary. What three things should the reader of this article keep in mind? What are some of the things that are important takeaways from your article?
One thing in terms of obesity care in general is to appreciate that there are multiple tools in the obesity care toolbox. I really try and use the language of obesity care and not weight management anymore. I think our knowledge about obesity has changed. We as dietitians don't own weight management. It's not all about diet and exercise. Diet and exercise lifestyle are certainly the foundation, and regardless of the intervention, diet, exercise are important for everybody, but they're not enough for everyone. So to appreciate that there's multiple tools in the toolbox. I think the second area is that shift in our role that I just mentioned, that it's not always about a calorie deficit. So meeting the client where they are, working with them on realistic changes for long-term health, being able to look, I think, the whole picture very holistically at our client, not just focusing on the number on the scale. And I think the third thing to appreciate is the need for advocacy in this area. One of the largest barriers to access to these medications is the cost, availability and cost. So advocating for access to medications, being aware of the regulations, the coverage, but also advocating that the RDN is part of the obesity care team, that we have a role working with our colleagues, physicians, nurse practitioners, exercise physiologists, psychologists, part of the team with these medications, really just like we see with metabolic and bariatric surgery. Dietitians are part of the team. we need to view that same team model with obesity medications.
Yes, so important for the RDN to be a part of the team. Important idea. And then how might the practicing RDN use your study results in a clinical setting?
I think first, I would encourage every RDN to review their scope of practice. First, overall, their scope of practice as an RDN, but look at the SOPP for adult weight management, and also the SOP with diabetes care. Look at the current editions of those. Think about what am I doing at the proficient level, and then how can I become more competent up to the expert level? How can the RDN actively assist with obesity medication management based on the level of practice, ranging from competent to proficient to expert? And people practice in a variety of settings and certainly have a variety of clients. So think about the role. And then that often leads to, well, what additional continuing education or credential might be beneficial if you're working in obesity care a significant amount of time? Consider additional training, perhaps the credential, the CSOWM, the Certified Specialist in Obesity and Weight Management, to really, become that expert in with obesity care. Work with providers. As I said, be part of the team and advocate for the dietitian being on that team. That may mean taking on increasing responsibilities to work at the top of our scope of practice. And that may include, helping to develop protocols and policies regarding obesity medications and what the RDN can do with recommending dose adjustment, managing side effects, and so forth.
Thank you. And finally, you provide some excellent thoughts in your article conclusion statements that I feel really move the profession forward. What final messages do you have for Academy members listening to this podcast?
I think the future is bright. And this is an evolving area of knowledge. I think it's really important to understand how our understanding of obesity has evolved. That it's a complex disease. When I began practice years ago, really it was weight management. We were working with people on fewer calories in and more calories out. And it certainly has evolved beyond that. Our understanding of disease has evolved beyond that. So I think recognizing that obesity is a chronic disease, helping our clients to understand that it's a chronic disease that can be treated. We're not curing, but we can be real advocates for our clients and helping them to understand this as a chronic disease and the interventions to help management for overall health.
Thank you so much, Linda, for providing just a beautiful summary of your article. But I think also you've provided some very timely messages to our Academy membership along the lines of working as a team. And thank you so much for responding to my questions and participating in this podcast.
Well, thank you for the opportunity. I appreciate it.